Hi, good evening. I'm Dr. Gary Howson, the GP in Cambridgeshire and Vice Chair for External Affairs at the RCGP. Welcome tonight to the next in our series of RCGP live panel debates. This evening we're going to be discussing the government's proposed health and care bill and what these expected reforms will mean for us as GPs, for our communities and for our individual patients. You can put questions to us on the panel using the hashtag RCGPLive on social media. And if you're watching directly on the YouTube feed, then please just post your questions below the video. We've got members of our team looking out for the questions and they'll put them through to me and then I can put them to the panel. At the end of the evening, the video will be captioned and a full transcript will be made available after the live event. We've got a couple of live polls running on our Twitter account at RCGP, so if you'd like to have a look there and join in, that would be much appreciated, and we'll have a look at the results of those polls later too. So to the content of tonight's agenda. In February this year, the government announced that it would be introducing a health and care bill that would create what they called a truly integrated healthcare system with less bureaucracy, and to ensure that NHS England is accountable to taxpayers that use the system whilst maintaining its clinical and day-to-day operational independence. The bill is due to be published imminently with an aim for the reforms to come into effect as early as April next year. We did expect the bill to be tabled this week, but as you'll have noticed, we've got a new Secretary of State now, and that appears to have built in a bit of a delay. Amongst several of the significant changes, the bill is expected to formally introduce integrated care systems in every part of the country, place a duty on NHS England and local authorities to collaborate on the delivery of care and providing NHS services. And it will also mean that the Health Secretary will have powers to intervene in the reconfiguration of services. Tonight, our panelists will talk about these expected changes, what it means for us. We'll assume that we have a very low level of understanding, as we know we'll have membership of the college watching, as well as other members of the public through YouTube. So if at first you think the level is a little bit too simple, don't worry, we will be building up to some of the more detailed nuances in the discussions. So we've got a lot to get through this evening, an awful lot to talk about. What I'll do is I'll ask each of the panelists to introduce themselves when they answer their first question. We're looking on social media today. Only 20% of respondents said they had any idea what an ICS is and what it will mean for our patients and our practices and our communities. So if I can go over to the first panel and ask you, Ruth, please to introduce yourself. And what do you think are the key changes in the bill that GPs need to be aware of?
Good evening, everybody. Thank you, Gary. I'm Ruth Rankin. I'm Director of Primary Care at the NHS Confederation, where I run two networks, a network for primary care networks and a network for GP federations. In terms of the key changes from the bill for, I guess, from a PCN perspective, the thing that PCNs are most worried about is actually clinical commissioning groups, CCGs, will disappear and be replaced by ICSs. And I think whilst there has been variation across the country in that relationship between PCNs and CCGs, there are a lot of PCNs who really value the CCG role. And obviously with ICSs covering larger geographies, I think PCNs will fear the loss of the local relationship with CCGs. So that will be a big change that will be introduced by the bill. I think the second thing is that obviously the one of the other key changes from a secondary care perspective, but will impact on primary care, is that secondary care will move from payment by results into block contracts. So I think that can work both in primary care's favour, but also to its disadvantage. So, for example, with block contracts, obviously they are paid for an amount of activity, and that means they will be more keen to manage the demand within that block. But equally, it also means that primary care has the potential to get faster access to advice and diagnostics, because rather than patients being taken into secondary care will be more keen for it to be managed in primary care. So, you know, that is an added benefit that we see. And I think thirdly, there's a key focus in the bill on population health management and health inequalities. So we expect to see contracts across the NHS being much more focused on outcomes rather than inputs and targets. So, that's a good thing for the system, for integrated care and for patients.
Excellent, thank you, Ruth. So that's touched on a whole host of things there and a significant number of changes. Perhaps I can come to you next, Richard, please. Same question.
Thanks. I'm Richard Vautry. I'm the chair of the BMA's GP committee in England and UK, and a GP in Leeds. And follow on from what Ruth has been saying, I think one of the key changes is what happens to the GP voice, what happens to the influence that GPs and their teams can bring to bear on the health and care system in their area. So with the advent of CCGs, for good or ill, we did see that practices were members of the CCG, and there was a responsibility of the CCG to engage with all practices. And clearly that's going to change with the loss of the CCG, not only that local engagement, but potentially making decision-making more remote. And I think one of the key elements is that the ICS, the more regional body, needs to devolve responsibility and decision-making as locally as possible back to the place that many of us would work in, sort of our cities, our towns, our areas may be covered currently by our CCG. And we need to empower general practitioners and others working in general practice, practice managers, sort of, and other staff, so that they really do feel that their voice is heard in the decision-making at that level, and that we ensure that that takes place. It's also imperative that it's broader than just practices, because clearly there are many GPs who work outside of practices, sessional GPs and others. And so involving the local medical committee, who represent the whole of general practitioners within an area, is absolutely crucial, because they are the statutory body. They've been around for 100 years and more. We've seen organisational structures change in the NHS on a regular basis, but the LMC remains the stability point sort of, within the system. So it's really important that the local medical committee has that fundamental involvement in the system, both at place level and at the ICS level. And then again, as Ruth has alluded to, what this will mean at a local level, in the partnership level, is a bringing together of decision making between the community settings, that's primary care, general practice, community setting services, and hospital services and secondary care services, working together, we would hope, in a collaborative way to make appropriate decisions for their community. Now, that sounds like an ideal situation, but clearly it brings with it huge potential tensions when it comes to deciding how the resource is spent in a local area. And whether that resource can be retained in general practice and built upon in general practice, rather than what we've seen in the past, whereas resources get sucked into secondary care. And we really need to avoid that. General practice needs resourcing, and it does not need resources being lost to other parts of the system.
Excellent, thank you, Richard. And so far we've touched on impacts on the system, we've touched on impacts on PCNs and networks. Perhaps I could come to you, Rupert, for what you think individual GPs and individual practices need to be aware of with regards to the proposed changes that are ahead of us.
Thanks, Gary. I'm Rupert Joshi, and I'm a GP from Berkshire West, and I'm also a clinical director for Wokingham North Primary Care Network. So in terms of GPs, how is this going to affect us? We can look at it as an opportunity of looking at our populations and the inequalities that exist. We've always had a one-size-fits-all approach, and we've been told, these are your QOF targets, these are your DESs. And what we can really do here is we can look at our own populations at a grassroots level. We might be GPs in inner city areas with homelessness, deprivation, or we may be in rural areas with high elderly populations, loneliness, isolation. So what we can do is use our voices to say, this is what we need in the system at place level. And we are able to, if we can get together and get our voices heard, and we can use that voice to get the services that we need to be more tailor-made to the actual populations that we serve. So I'm looking at it as an opportunity to really get through. It's got to be different. What we don't want is all these changes to divulge into one large version of a CCG where the same thing's happening again. what we want to do is have true partnership working and engagement, to the point where we've worked so hard during COVID, haven't we? All the GPs looking at vaccination inequalities, working through with our voluntary sector organisations, our local government, our public health, how to reach out to our populations. And in that, we have built these wonderful, trusting relationships with our community colleagues. So let's build on that. Let's build on it from grassroots level, get our voices heard, look at place-based partnerships and escalate that to ICS levels. At the ICS level, there will be two main statutory boards. So we will have our NHS body, which will have at least one person from general practice, if not more. We're hoping more, so that we can get our voices heard, with secondary care colleagues, community colleagues, local government. And then there'll also be another board, which is the Health and Care Partnership Board. And that is essentially where social care, local government can come together and make these decisions. So big changes will be decided at that ICS level. But what we need to do is make sure that our grassroots voices go up through place-based partnerships up to ICS levels.
Excellent, thanks, Rupa. So, I mean, for the uninitiated, it's already sounding a bit like an acronym soup here with sort of ICSs, PCNs, FEDs, and all the rest of it. And we will talk a little bit more about structures that have been sort of highlighted in the guidance that we've seen so far later on. But I want to try and take it back down to what difference could this potentially make for patients? Because I'm a CCG chair, and one of my observations is if you want to see collaboration in action, you couldn't really have done it better than what we've seen through the vaccination programme, which has brought together communities, primary care, community providers, local authorities, in a way with a sort of a fixed mission and a real passion to get things delivered. So, Ruth, again, if I can come to you first, please, can you see of any potential advantages for patients? What difference will it make to a patient sort of being treated under an ICS structure rather than under a CCG structure?
So, Gary, if we go back to the vaccination programme, I think it's a really good example. And, you know, why did it work so well and why was there so much collaboration? And I think the first point is there was a clear purpose. You know, everybody got behind the purpose and worked together and collaborated. And I think if you take that forward into what the future system might look like, it's got to be the same. So the system has got to have a clear vision for what it wants to achieve. And I think building on what Rupa said is it's very to have a system, and you know, and this is clearly set out in the bill, which is focused on the health of its population. It's working alongside local authority, it's working alongside NHS providers, it's working alongside patient groups. So people are clear about what the challenges are in the system. And in terms of investment, the investment is following where those challenges are, and it's really being invested in the areas, whether that's geography or in the sector, whether that's in acute trusts, in primary care, where it's most needed. And you know, I completely agree with Richard. You know, primary care is the backbone of any system, and yet we don't see the same level of investment in primary care that we do in the secondary care sector. So we've got to recognise that role. We've got to focus on the needs of our population and our communities, and the system. Through the partnership board arrangement with the local authority will make sure, hopefully, that we've got the plan right and that we're investing our resources in the right areas. And finally, that supporting all of that, providers are working together, because my fear is that as sort of, you know, the COVID, we're not out of COVID, but certainly in terms of hospitalizations, they have reduced. And now we're starting to address the backlog. My fear is that I can already see people sort of starting to work again in their silos to address their own pressures. And I think if we lose that collaboration that we saw out of the vaccination programme and how we worked through COVID, I think that would be a real shame.
Thank you. Richard, I want to come back to you and pick up on one of the points you made about resourcing and about the distance between the board that will be making decisions about allocations, if you like, at the top of the system and where we're actually delivering care. Now, we know that there's strong evidence from across the world that empowered and well-resourced primary care is required to make a success of integrated care systems. We know that the majority of patient contacts takes place in primary care. And we know that there's lots of different voices calling for different things under that umbrella of primary care. Now, you've mentioned the importance of LMCs as a statutory representative for everyone in general practice. How do you think we make sure that GPs who quite frankly are too busy running their practices and looking after patients are able to engage with this process, and the people that are representing them really understand that we need to have influence at a whole host of different levels within the system? How do we go about that and not creating so much noise in general practice that we drown ourselves out?
Yeah, I mean, it's going to be a real challenge. I mean, keeping track of the pound, I think, is going to be, you know, a real art, and it's really important because whilst the national contracts, you know, GMS contract, PMS funding will continue to be determined nationally, and the funding linked to that sort of will be provided to practices as it is now. We know that many practices now depend on significant proportion of their funding coming from local sources, you know, from the CCG, sort of from local authorities and other sources as well. So it's really crucial for the stability of general practice that we maintain those funding flows to support our practice workforce, but also that we utilise the much wider funding budget within the NHS as a whole in a more imaginative way. So there is potential, again, coming back to the collaboration issues, to look at areas that potentially bodies like hospitals have been doing, but have been doing because it's been in their vested interest to continue doing something because the funding followed that. And if they didn't do that, they would lose the funding. Well, it may be if we start to break down some of the barriers between primary and secondary care, if we move away from the historic commissioning provider split that we've had now for over a generation, and we genuinely do start to collaborate with one another, we might find that we can actually develop a service in a better way for patients and a better way for clinicians as well, that actually starts to bring together specialists and generalists in a more productive way, maybe often delivering those services in a community setting, but done in a sustainable way so that the funding follows it and it isn't done in a way that just assumes general practice will pick it up for free and be expected to do more and more work, but genuinely ensures that the resources are there to make sure that service is stable. So you can imagine things like, you know, a diabetic specialist working alongside those with a special interest in diabetes, maybe community diabetic nurses and others, working in a collaborative way that actually supports and enhances diabetic care, but also takes the workload pressure off some of general practice as well, in terms of some of the things that they're doing at the moment. Similarly, maybe more specialist areas, sort of, you know, where you get particular specialists, again, working alongside others in the community and sharing their knowledge and skills and expertise in a way that patients actually benefit from as well, because not least, they won't have to go to the hospital and find somewhere to park, because they'll actually be able to find somewhere within the local community instead. So I think there's lots of potential. I remember when I started in general practice too many years ago that I care to remember now, we actually knew the consultants and the specialists in the hospital a lot more than we do now. I think since we had that commissioning provider split, the barriers have gone up, sort of, we've lost that connection with our specialist colleagues, and it would be really helpful to rebuild them again, but also to be honest about the funding that's linked to particular services, because many of our hospital colleagues really don't know what it costs to run particular services either. And what we need to ensure is that we're dealing with clinicians who are active on the ground, whether that be in general practice, community settings or hospitals, and not just those who are leading for management purposes, you know, hospital services or clinical directors.
Brilliant, thank you, Richard. Rupert, I'm going to come to you with the next question, if I may, please. And it's around those relationships that Richard's just been talking about and breaking down boundaries, because that's got to be one of your key roles as a PCN CD. We also know that there's no legislation that's going to, you can't legislate for better relationships, you can't legislate for more integration. And I think one of the challenges we've had is that in many parts of the country, general practice is smaller in scale, less mature in organisational terms than sort of the foundation trusts and, if you like, the big players within the system. And primary care networks are fairly new entities within our system still. They've done an absolutely fantastic job through the vaccination programme, but they're still in the maturation stage organisationally. And we can question the degree of leadership capacity that they've developed to take on this sort of enhanced role within the new system. So what sort of additional resources do you think we need to make available for people like you as a CD to allow you to build those relationships, to build integration, to really make the differences that this bill is trying to achieve?
Thanks, Gary. Let's not underestimate the impact that COVID has had on the system. So that's including general practice, the work waiting list backlog, mental health, the strain it has had on primary care, the GPs getting home later and later every night. So there isn't much headspace, and particularly for CDs who are trying to run primary care networks and also trying to run the vaccination programme. It has been difficult. It's been very welcome, the full-time reimbursement that we've had as CDs, and also very welcome the development funding monies that we've had to help with leadership. There are lots of programs out there to try and help CDs, particularly with the Confed that's been really helpful and giving us lots of advice and guidance. But yeah, I think there is definitely a need. If we want to be on the same footing as the chief execs in secondary care trusts, and we want to try and eliminate this hierarchy that currently exists in the NHS, to build those trusting, equal partnerships at this level, because at the end of the day, the patient is at the centre, and our role as healthcare professionals is to work together for the benefit of our patients. We are their advocates. We need to stand up for those that are vulnerable and are unable to speak for themselves. So having that leadership support, I think, is absolutely essential. Many CDs have struggled. I think it's a huge step from a lot of the skills are transferable, as we have as a GP. But there's a huge steep learning curve. I think I've been doing the role now for 2 years, and I have learned so much over the last 2 years, and I've still got so much more to learn. But yes, definitely leadership support is very much needed in the system to help us, first of all, build those relationships, be seen as equals, and also be able to be that primary care voice within a very large system.
Brilliant, thank you, Rupert. Just before we leave sort of this first area behind, where we're talking about key changes in the bill, I just want to come to you, Ruth, and ask about the networks that the Confed set up. I mean, I've spoken to a number of CDs, and one of the issues they face is it's quite isolating. They're so busy trying to get the work done that the ability to network across their systems has been somewhat reduced. And yet it's really important that they have a combined voice to steer decisions within their individual systems. What are you hearing from your networks about the changes they're expecting to come from this, and sort of the big opportunities and perhaps some of the big challenges in making sure that this works for general practice and it works for our patients?
Thanks, Gary. So we've got a number of networks within the PCN network at Confed. We have a board of 28 PCN clinical directors and PCN managers. We have a regional clinical director forum in every region. We have a forum for clinical directors who are nurses, and we have a forum for PCN managers. So we get a lot of, I guess, intelligence across all of those networks. I think, not wanting to be flippant, but some of them are saying, I don't understand the system. What is the system? It just feels so far removed from where I am in my primary care network and in my practice. And if you look at some of the sizes of the integrated care systems that are in their shadow form, they're covering vast geographies. So where the PCNs have previously enjoyed that more local relationship with their clinical commissioning group, as I said when I started, they are worried that they lose that relationship and that support, and that additional funding, and I just guess some of the support and advice that they've enjoyed, and to become more mature. PCNs, whilst being 2 years old, are still relatively new organisations, and the last 12 months of their sort of life have been focused on COVID and the vaccination programme. So they're still at very early stages. I think that what's important at a primary care network level is that they can see a system that is focused on the patient, and that they can see the golden thread from the challenges that they are facing with their own communities right up to the system plan and the system priorities. And that is the big concern, because the geography is large of some systems, the demographics are, the difference in demographics is vast. So the question that primary care networks have is, how can that system represent everyone and ensure that everyone's needs are catered for, given the variation and challenges that we've got? And I think, as Rup has said, and it plays the point about the maturity of PCNs is variable, at varying stages in their development, is they still need a lot of support at a local level. And so whether it's a place or a system, what we want to see is systems and places really giving PCNs that support. And effectively, you've got a mini organisation that's got a part-time clinical director who's maybe a day a week, in some cases a part-time manager, but we are just loading more and more into networks to be, to take responsibility for, and that is just not sustainable. So we need that support in the leadership and the management infrastructure.
Okay, thanks, Ruth. I want to take us on to a second area of discussion, which is around one of the other questions we were asking through social media today, and that was asking people what they thought the impact on patient care of these changes would be. And 80% say they've got concerns or significant concerns about the impact on patients. And ultimately, we've got a duty to make sure that outcomes for patients are at the heart of any sort of structural and architectural changes we make within systems. So I think, Richard, you've already touched on a couple of areas that we need to think about, but in terms of day-to-day running of practices, I often hear sort of GPs who are a bit longer in the tooth saying, look, the only three things that are going to be here consistently are the patients, the practices and the hospitals. Everything else just is constantly changing and moving, and we've got to look after practices because that's the unit that's going to be here forever. Is that just GP self-interest, or is it really important that we do keep a practice footprint as well as these different layers as we move up through the system?
I think it's essential, Gary. The reason why patients trust us is not just their direct relationship with their individual GP, sort of your team. It's because they're at the heart of the community, and communities may have lost their post office, the schools, various other services, other services in our charge. The only free service in town often is the general practice service, and that can be a plus and a minus as well. We know about the huge workload burden and the expectation that GPs will do everything and anything for everyone, but nevertheless we are at the heart of communities. And that's one of the great strengths of general practice. We know our communities as well as knowing our patients. And that's what we'll bring to the new arrangements of, that local knowledge, that local understanding of our patients, and also the real challenges that they face. And in many parts of the country, within 3 or 4 miles, you get very, very different communities, from significant areas of deprivation to more affluence, to commuter areas, to rural and remote areas. So I think we do need to see the benefit that general practice brings to that discussion through that local knowledge. And that will help our hospital colleagues and others as well, who are maybe working in bigger organisations, maybe more remote, from particular communities. So I think we play a really important role in really anchoring the local ICP. And I go back to the point I was making earlier. I think it's absolutely imperative that the ICS, the overarching regional body, devolves as much power, responsibility and resources to the local area as possible, because that's where the key decisions can be made. You can't make them 40, 50 miles away. You need to be making them at the heart of communities and together with the local practices and teams that will be delivering those services.
Excellent, thank you. And Rupert, I just want to pick up on some of the challenges Richard's mentioned there and around population health management, because some would argue that population health management needs to be done at a massive scale. Others would say it's all about what goes on in very local communities. I mean, if you look at the King's Fund model for population health management, it talks about needing the wider determinants of health. It's about our health behaviours and lifestyles. It's about the places and communities we live in and live with, and an integrated health and care system. Now, we're just talking about 1/4 of that model. How do we make sure that GPs at the heart of our communities, as Richard's alluded to, that really know the problems and the issues within our communities and really understand and hopefully can influence those wider determinants of health? How do we make sure that we have a really strong general practice voice to make sure that we influence not just one element of that, but all 4 elements?
I think GPs, as Richard was saying, we are the heart of the community. We know our communities well. What we found most beneficial from our population health management data, and we're fortunate because we were a wave 1 site, so we were quite early off the ground with that, what we found is it's filled in the gaps for us. So it's filled in what are we missing, who's not coming to see us. So using our population health management data, what we've noticed is that in our deprived areas, in those postcodes that we checked, we have higher HbA1cs in our diabetics, we have higher blood pressures, we have increased smoking status, higher levels of use of services, medical services. So what can we do to help those patients? We know that they have they get admitted to hospital. So with our health and wellbeing board, our local health and wellbeing boards, we have the expertise of our voluntary sector organisations, public health, local authority, our council engagement officers have been fantastic. So what we're doing is we're picking up, so for example, another thing that we've picked up that we didn't realise was who's coming into the practice, and we've realised that Black men, we are missing depression. We have 1/3 attendance of what we have with white and Asian populations attendance over a year. And so we're not getting to see these patients. So how do we go about engaging them? What's the best way of saying we are here if you need us? Do we do that in a non-medical way? So do we engage our community leaders, our faith leaders? Do we engage social media, or what's the best way of reaching those people? The NHS can't do this alone. We need help. We need help to reach our patients that they're not coming into us. Why aren't they coming into us? Because it may be a cultural thing. It may be that we're maybe not welcoming them. They don't see themselves as patients. So that what we need to do is use the community in this way and reach out through other non-medical areas. And I think we've been doing that really well through COVID, because we know this, we've got a huge mental health problem going on at the moment. So with our Health and Wellbeing Partnership Board, we've organised for Mind, the voluntary care sector organisation, to see patients through the one front door, which is through the local local council offices, that they can access them through a phone number that's on social media if they've got any stress problems and they need to see us, and then they can then be directed to us if they need to. But otherwise, they can have health coaching, they can have discussions with voluntary organisations, they can get signposted to services. We've got link visiting schemes for our elderly, and we've managed through the vaccination scheme to really connect with our residents who worship at the local mosque. And through that, we've looked at training up volunteers from the community to become link visiting colleagues as well. So it's all about making those connections. And we touched on that earlier about how do we engage people. I don't think it's about how we help people, it's how we empower communities to help themselves. So what we need to do is say to people, what do you need? And we will enable that for you. What's your voice? We can't go in and take over. I think it's got to come from the communities. So I think PHM data, the population health management data, has been really invaluable in spotting those gaps, and also giving us that data we can use that data to engage people and say, look, this is what's going on in our community. These are our patients. What can we do about it? And that engagement piece is so hugely important to get everybody, all the members of the team on board.
Brilliant, thank you. So we know what we want to achieve, we know what we want to influence, and we know that we're in a really good place to do that. One of the things that's came through strongly on social media today through the polls that we were doing is that people can see a whole host of potential barriers. And Ruth, I just wonder if I could come to you for your views on some of those barriers. The things people are talking about are the obvious ones, like too few voices at decision-making tables, but other ones around a clear lack of system leadership pathway. So how are we going to develop the leadership skills for the GPs, not the usual suspects now, but as we move through, how are we going to take those people that are very influential, but just starting out on their sort of local leadership journey and make sure that they're ready to sit around the top table in 5 years' time? Because we've really got to have an eye on succession planning to make sure that not only do we become influential in the system, but that we stay influential in the system.
Yeah, and it's really important point, Gary, and obviously we're waiting on the next set of guidance from NHS England in relation to clinical leadership and what that looks like in the new integrated care systems. And NHS Confederation, because we represent the whole system, has done a piece of work to engage with clinical leaders across all sectors within the health system to understand what does good clinical leadership look like. I think it's your point about, certainly in terms of primary care, when we first set up the PCN network, we surveyed primary care clinical directors, and of those that responded, 50% were in their first clinical leadership role. So there is a massive need for investment in them as leaders. And I think what we have seen over the 18 months the network has been running is, certainly in terms of our board members, who some of who were brand new leaders, they have grown over that period, because it's about understanding not just what's happening within the practice, not just what's happening within the PCN, but what is happening in the wider primary care community and in the wider system. So, and understanding their role within that, and building those relationships and making the connections so that your voice is stronger and that you are truly representing primary care. I think when it comes to representation on the ICS board, it is an issue that PCN clinical directors have raised with us. You know, they don't necessarily feel that they are able to sit at a board with acute trust, community trust, mental health trust chief executives, because in some cases they're speaking a different language. So we need to invest in primary care, clinical and non-clinical leadership to make them feel that they have confidence in sitting at those tables and having those conversations, and you know, and that's across the board, at whether that's at system board level or at place level. But I don't see the investment in primary care leadership in the way that we have seen in other parts of the system.
Okay, thank you. And that's something that I think is critically important that all of us need to keep pushing for. Richard, I want to move on to something around timelines, because I mean, I think the government need to have realistic expectations and communicate clearly around the amount of time it's going to take to develop these relationships, but also the sort of collaborative culture that's going to be required. In order to do that, we're going to have clinicians really engaged with new ways of working. And quite frankly, the workforce is spent at the moment. You know, they're done in. We've been working above and beyond now for 18 months, and there's a lot of initiative fatigue. A lot of people have seen these changes come one after the other. So what role do you think you have, or we have, in making the government understand that this is going to take time? One of the criticisms we're getting is that this is putting another huge burden on PCNs, and PCNs were initially there to support and stabilise general practice, which was at crisis point, and yet there's a whole new load of burdens being put on them. What's your take on that, and how we can communicate clearly, one with the government and two with our patients, so expectations are set properly?
I think you're absolutely right, Gary. whenever the NHS changes, and it changes far too often, you spend at least a year, 18 months actually just bedding down the changes, sort of, people developing the relationships before anything significant really gets done. And we've been through a massive turmoil over the last 18 months. We're still living through that now. And you're right, general practice is absolutely spent and hasn't got the headroom to think about sort of, the next day, let alone sort of, changes that are happening over the next few months or years. So I think we do need the government and NHS England to really understand that properly and to demonstrate that they understand that properly, not just plough on with yet more targets, yet more goals. I mean, we saw just at the NHS board meeting last week, the release of a whole series of NHS metrics by which they're going to measure the system over the coming year. If we carry on with that top-down culture, then it's going to really be a recipe for disaster for local systems, because people won't want to get involved. They feel that they're being beaten by a stick and performance managed in a way that's completely inappropriate. And that's not what GPs would want to be involved in. So I think we do need a different culture at the top, and maybe the changes in Health Secretary and leadership in the NHS England over the coming weeks will provide an opportunity for that change. But then we do need people to be given time and space, both to learn and develop, but also to make mistakes, because you won't get it right every time. And I think we need to be in a culture that genuinely learns, not assumes that everybody is going to be perfect the whole time, but gives people opportunity to test things, to have time to analyze them, and then to roll things out, sort of, others maybe have done better. So I think we do need that space. We need a learning culture, but we need a forgiving culture as well. So that we don't sort of assume that as soon as somebody gets something wrong, then they're going to be held to account and hauled over the coals, because that will really put people off very, very quickly.
And we know one of the biggest challenges going forward is that we're likely to move into another era of flat cash, because sort of the COVID money tree is withering on the vine, and we're going to have to get back into the situation where there'll be a much bigger focus on financial resources again. And that always plays into this tension of sort of saying, look, GPs are at the heart of your community, you know what you need to influence, you know what you need to change. And then this massive top-down regulation that really suppresses innovation. So how do we go about dealing with that? Perhaps, Rupert, I could come to you and ask that as someone who's working really close to the front line. You must get fed up of knowing what you want to do locally, but always having someone looking over your shoulder telling you you can't do that because of X, Y, or Z. How do you manage that?
Absolutely, I completely agree with you. It's an immense source of frustration for primary care and all our colleagues. The aim of this bill, the aim of in integrated care systems, is that the resources should follow the patient. And we do 90% of all consultations. We are really poorly resourced and we are struggling. We know that we've got workforce issues. We know that people are on their knees. We know that people are not getting home to tuck their kids into bed at night because they're still at work. So there's a huge resourcing issue, and we really do need that funding. We know that secondary care is being funded for their backlog issues, and we need to see something similar in primary care to really help our struggling workforce, and we need to see that really soon.
Excellent. Okay. Thank you. I'm going to touch on a little bit now on the structural stuff. We have had some guidance as to what the architecture is going to look like. And Rupert, you talked about that earlier on. We're going to have an ICS sort of NHS board, which is going to be responsible for sort of allocation and running the operational side of the health bit. And then a second partnership board, which is where the other wider system players and local authorities and the like will be. And the health board is going to have to take note of the strategy that the partnership board develops. And then sort of in layers below that, we talk about integrated care partnerships, and then down to PCN networks and the like. Ruth, could you just touch very briefly on what they've said about what the ICS board's going to look like in terms of who's going to have to sit on that, the mandated roles, just so people have an idea. Now, obviously, that's not going to be the only answer because there is some local flexibility in who else can sit around there. But just so people have got an idea what the mandated bit's going to look like, please.
So essentially, what the guidance says, Gary, is that there's obviously a chair and chief executive who are full-time members of the board. In terms of those others that sit on the board, there is a representative from primary care, and they have defined that as general practice primary care, as opposed to differentiate from optometry, pharmacy, dentistry, and a representative from NHS trusts as well. There will obviously be other members of the board in terms of other executive members. So, medical director, nurse director, but the process for appointing those members is as yet unclear. Obviously, the bill is delayed at the moment, so that further delays the process of making appointments. What they've been very clear to say is obviously they've set out a minimum expectation. So for primary care, whilst they've said a minimum of one seat on the board, what we would expect, we don't expect that to look the same in every system, but equally we expect systems to think over and above that one seat to understand actually what makes it work in this system. And there's lots of conversations at the moment going on with primary care providers, with LMCs, to understand what's the best model for us. And actually what we're encouraging people to do is think about that from the bottom up. So don't be dictated to from the ICS level in terms of what they want to see, but actually get together now as GPs, as primary care teams across federations, LMCs, primary care networks and practices, to understand what works for you, how you're going to represent yourselves collectively, to make sure, because it's less important who does it, it's more important that primary care has a voice and that it's the right voice.
Brilliant, thank you. And I think the really important message to take away from that is, and people are saying, once you've seen one ICS, you've seen one ICS. They all have to be different. They've all got a different issue that they're trying to fix. And although the guidance is sort of mandating one element, it is down to local ICSs what it looks like locally in the final construct, and GPs can influence that. And it's really important that we take the opportunity, despite everything else that we're trying to do at the moment as well, to have an influence on what it looks like locally. I want to move away now from what the bill is talking about to some of the criticisms that have been floated around the bits that it's not talking enough about. Now, I guess one of the tragedies of the COVID pandemic was the fact that it shone a light so brightly on the health inequalities that pre-exist in the way that services are provided, in the way people access that. And lots of people saying the bill doesn't go far enough in tackling health inequalities, it doesn't go far enough in talking about the workforce, and it doesn't address the workload crisis that we're facing in general practice and the wider primary care and community teams at the moment. What do you think could be done through the bill to implement or influence things in those areas? And if I could start with you, please, Richard.
I think it's difficult to do this in a prescriptive way nationally. I think doing that through legislation, through the bill, becomes challenging. I think certainly one of the things that we would really want to ensure is that the new powers that would potentially be given to the Secretary of State aren't misused. So we would want to ensure that NHS services are commissioned and not private services, and we want to ensure that proper appropriate probity is there in terms of how services are commissioned nationally, not what we've seen in elements during the recent last few months where services have been commissioned that have been maybe done in a less than opaque way. But I think we need to ensure locally that there is an emphasis on health inequalities. Now that's written into a whole range of government guidelines, NHS England guidelines, but often we pay lip service to it because we don't provide the necessary funding to really address it. But we also need to recognise, and you've highlighted in the structure of ICSs, that there will be the clear partnership with local authorities as well, because health is much more than just the medicines that we prescribe and the treatments that we offer. It is about housing, it is about environmental issues, it is about a whole range of other issues, education, employment. So I think the clear working with local authorities is one of the main ways that we'll try to address many of the inequalities. But that really does require the funding, because we know that local authorities are cash strapped as well, and don't have the headroom either to make the necessary investment into local areas and local services in the way that we would want to. So if the government is really serious about health inequalities, rather than just writing something into a bill, they need to provide the funding for it to ensure that we do genuinely do what the government wants to do, which is level up, and not what we fear might happen is level down, because the funding isn't there to be able to support the services that we think are essential.
Brilliant, thanks, Richard. Rupert, if I can come to you, I want to ask you a question about engagement with this. And, you know, if there's people out there that are sitting, listening to this and think, actually, there's an opportunity for me to be able to influence something I'm starting to feel really passionate about in my locality, how do they get involved? How do they engage with this new process? What advice would you give our GP colleagues out there that want to become more involved than perhaps they have been in the past?
My advice would be that you know, a GP is part of the ICS. We've got to see ourselves as leaders, as people that understand the system, that can influence. So I think first of all, we've got to see ourselves in this role. Once you start meeting people, building relationships, talking, we've all got a shared purpose. It's working out what your shared purpose is around the patient's needs. We've got a fantastic health and wellbeing board, and we've got to the stage now where we can phone each other, say we'd like some advice, we want to reach this group of patients, what do you think? They've been coming along to our vaccination clinics and volunteering with us, so we've built up excellent relationships. And I would say, you know, get details, phone people up, email them, ask them for advice. It's possible, and I know many regions where this is working brilliantly, and there's no reason why it can't work in your region. So get out there if you really believe and you're passionate and you want to do something to change the way that your patients are looked after, the services that your patients are offered. You can do it. You just need that confidence and that passion, and knowing that you will be listened to by your local authority colleagues. And if you're not sure, then speak to your public health consultants. A fantastic resource. I think they're underutilised. There isn't a great, you know, there's still some barriers there in some regions. We've managed to overcome it, but yeah, pick up the phone and have a chat with people. It's possible.
Brilliant, thank you. And presumably at an even sort of more local level, if anybody who's out there that wants more information about what's going on locally, have a chat with your clinical director, because they'll know what's going on in your very local footprint. Infuriatingly, we're starting to run out of time already, which is always a problem with these conversations, which could go on for ages. I'm going to come to you, Ruth. You talked earlier about the fact that there's you know, with the change in Secretary of State for Health, that there's been a delay built into this process. Now, sitting here as a CCG chair who's facing three massive challenges going forwards of sort of the COVID recovery, the winter that's ahead of us that is going to be really tough, but also transitioning safely to a new set of organisations potentially from next March. If a delay is built in and that goes on for too long, what's the consequences? What's that going to mean for the timelines? And what are the threats and opportunities that are associated with that, do you think?
So I think, I mean, let's hope it doesn't go on much longer, Gary, and certainly we're calling for it to you know, get through as quickly as possible, because as with any change or restructure, and we have seen enough of them in our lifetime in the NHS, you know, it's really unsettling for people. And I go back to the relationships that PCNs have with CCGs and people within CCGs. You know, people are going to start disappearing. If they're not clear about the future, they will start to move on, and processes and systems and relationships will break down. And I think that's, you know, that is incredibly risky for those providers that are relying on CCGs for funding or for support. I think things will just slow down. The development of PCNs will potentially slow down because they haven't got that support or that clarity on the future and what the future organisation looks like. So from our perspective, you know, it's a massive risk, and personally I don't see any opportunities.
Yeah, and I think most people would agree with that, Ruth. Thank you. I just want to take us on to one last question for each of you. If you could have 30 seconds with the new Secretary of State to talk about this particular issue, what advice would you give him? What would you want to get right at the front of his mind with regards to where we're headed with this potential legislation and all the structural changes? And Richard, if I can come to you first, please.
I think you've already highlighted, I think one of the key issue at the moment for general practice is workload pressure. So whatever happens sort of in these changes, it has to ease the workload pressure on not just GPs, but practice nurses, practice managers, pharmacists, others who are working in general practice day by day. So we can't expect more and more from less and less. So we do need to give people longer opportunities for consultations, longer opportunity to think about things, to design things, to work on things, but that needs resourcing. So the second thing is they has to ensure the resources flow to support that expansion in the general practice setting, so that we can actually both meet the growing needs of our patients and the population, but also reduce the burden on individuals. That's the crucial thing.
Brilliant. Thank you, Richard. And I'll come to the other two as well. So Ruth, perhaps if I can come to you next, please. Same question. What would you do in your 30 seconds with Sajid Javid?
I'd say don't forget primary care. Everything we see is always focused on pressures on secondary care, pressures on the acute sector, and that's therefore where a lot of the investment goes. And I think when we talk about workload in primary care, that's always portrayed in a negative way. And we've got to just change the conversation and recognise that the system is under pressure. We need a system-wide response. Providers can't do this on their own, because if one starts to tackle the problem in their sector, it will have an adverse impact on another part of the sector. So, you know, remember primary care, because the system is nothing without primary care.
Brilliant. Thank you, Ruth. And the reason I left you to the end, Rupert, is because if we're getting a message right from the sharp end, right from the front line, what are you going to tell him?
I would invite him to come and spend the day with us at the practice to really get an idea of what we're doing, what it's like to be on the front line, not just for GPs, but the whole of the primary care team, and to truly understand what the pressures are that we're currently under. Absolutely.
There's nothing like spending a day in general practice to understand what general practice is all about, and the diversity of general practice across the UK. I'm afraid we're drawing to an end of tonight's discussion. Just to let folk know what the college has been up to. The college has been involved in the conversations from the very beginning. We published our response to the white paper and the Health Select Committee back in March. At that point, calling for additional resources that we've heard a lot about tonight, and support for the primary care system needs in particular, and that's around leadership training, clear accountability, plenty of resourcing, and some space and some thinking time to work out how we're going to be able to maximise the benefits from this. Anybody interested in what the college is doing, if you Google RCGP health reform, it will take you to a new landing page on our website, which tells you all about ICSs, all about the proposed legislation and the timeline to date. We'll of course bring you more information as the bill makes its way through Parliament. Inevitably there'll be some changes, and a lot more we'll need to consider as we go through. But I'd just like to say thank you very much to Ruth, thank you very much to Rupert and to Richard for their time and their thoughts this evening. Thank you to everybody who's joined us this evening to watch, and for those of you that are catching up on YouTube afterwards. Any questions you have, please continue to post those through social media, and we'll find a mechanism to get the answers out to you. And finally, thank you to the backroom team that make this all possible, and make sure that we get these really important conversations out there. I hope some of you are inspired to get involved and to make a real change, because at the end of the day, there's some opportunities in here for the care we give to our patients and the outcomes they get from the health and care system. Thank you all again for joining us, and look forward to seeing you next time on RCGP Live. Good night.